Hi, everybody. I think most of you know me. I'm Jill Harlan. I'm the program director with the Community Liver Alliance. We're delighted to bring you the NASH Journal Club tonight. I'd like to thank our speakers and sponsor, UPMC. The Liver Journal Club was developed this year to bring you up-to-date information and to inspire a robust conversation among the medical community to learn and share. It's my pleasure to introduce you to our Fatty Liver Coalition co-chairs, Dr. Karen Jerome Zapatka and Dr. Maya Balakrishna. They're our moderators for tonight's program, and I will let them introduce our authors. Thank you so much.
Okay, thank you, Jill, and welcome to our second Fatty Liver Coalition Journal Club. We're so happy that you're joining us as we try to grow this. We're also very appreciative to our presenters this evening for sharing their articles and their expertise with us. I'd like to introduce Dr. Sai Jarapino. She is an advanced endoscopic and bariatric endoscopist at Brigham and Women's Hospital, a teaching affiliate of Harvard Medical School, where she also serves as Director of Bariatric Endoscopy Fellowship. She has clinical and research interests in the area of endoscopic management of obesity and metabolic diseases, especially on their application on non-alcoholic fatty liver disease. In addition to performing therapeutic procedures, including EUS and ERCP, Dr. Jarapino routinely performs both primary endoscopic bariatric procedures and a range of endoscopic treatments of bariatric surgical complications, including weight regain or inadequate weight loss. Additionally, she routinely prescribes lifestyle intervention and FDA-approved weight loss medications for patients with obesity and metabolic diseases. To date, her body of work comprises over 90 peer-reviewed publications in the field of endoscopic bariatric and metabolic therapies. So welcome and thank you so much.
Thank you so much, Dr. Zapatka. And I would like to thank everyone and also the organizer for the invitation. I'm very excited to be talking about one of my favorite topics on an endoscopic approach for the management of non-alcoholic fatty liver disease. All right, so the title of the paper that we published recently is Effect of Endoscopic Bariatric and Metabolic Therapies on Non-Alcoholic Fatty Liver Disease, a Systematic Review and Meta-Analysis. Here are my disclosures. So as we all know, NAFLD is the most common cause of chronic liver disease worldwide. And it is a spectrum of disease ranging from pure fatty liver to NASH, and then later on to cirrhosis. While fibrosis is not required for a diagnosis of NAFLD, it is the strongest predictor of overall and liver-related mortality. Traditionally, management of NAFLD has been weight loss via lifestyle modification. Specifically, the paper showed that we need to help patients lose at least 7 to 10% of their baseline weight for the NASH histologic features to improve. And if you want the fibrosis to improve, then you need 10% total weight loss. However, if you look at the studies, when patients undergo lifestyle modification, less than 10% of our patients are able to achieve this 7 to 10% threshold. On the other end of the spectrum, bariatric surgery can be considered in patients who are otherwise eligible for bariatric surgery. And this means patients need to have a BMI of at least 40 or 35 with at least one obesity-related comorbidity. So you can see that there's a big gap in treatment options for NAFLD, specifically for patients whose BMI ranges between 30 to 40, or patients whose BMI is greater than 40, but studies show that only 2% elect to undergo surgery. So what happens to the other 98%? They are limited in their options. And this is how endoscopic bariatric and metabolic therapies, or EBMTs, were invented about 15 years ago. Traditionally, when we think about bariatric endoscopy, we can break down the procedures into gastric and small bowel procedures. And usually for gastric interventions, we can do the procedure in the stomach, and this leads to primarily weight loss with secondary effects on metabolic diseases. In contrast, when we look at small bowel therapies, this usually induces improvement in metabolic diseases with or without weight loss. So I summarize some of the available or upcoming endoscopic options for weight loss. However, if you look at the market out there in the US, currently we have 4 interventions that are approved by the FDA and commercially available. The first one is an intragastric balloon. The second one is endoscopic sleeve gastroplasty. The third one is called an endoscopic gastric plication, which is similar to endoscopic sleeve, except that we use a different device. And the fourth option is aspiration therapy. This device still has the FDA approval. However, the company recently stopped making the devices about a few months ago. There have been a lot of data on weight loss for these therapies. Specifically, if you look at the data out there, a balloon can give patients about 10% total weight loss at 1 year. For endoscopic sleeve and also aspiration therapy, data have shown that patients lose about 15% to 18% of their baseline weight at 1 year. And just to give everyone like a quick overview, this is how we perform an intragastric balloon. So we pass an endoscope down and then pass a catheter down and then kind of inflate the balloon with 500 to 700 cc of normal saline with methylene blue. And then you can just pull the catheter and then leave the balloon there. The balloon that is currently approved in the US is approved for 6 months. So after 6 months, we have to do the second endoscopy, deflate the balloon and remove it endoscopically. For endoscopic sleeve gastroplasty, this procedure is becoming more and more popular. And you can see that we can use an endoscopic suturing device. The device is called the Apollo or the Overstitch device produced by the Apollo company. And we pass the scope down and we start at the incisor, and then we place stitches from the incisor along the greater curvature to reduce the volume of the stomach by about 2/3. And we gradually move up to the proximal body of the stomach. So at the end, we usually explain to the patients that their stomach is reduced by about 2/3 in volume. Similarly, a post procedure is another form of an endoscopic sleeve. This procedure we perform using an endoscopic plication device. It's produced by the company named USGI. And you can see, in contrast to this, we use the helix to pull the tissue in and then place like a mini staple inside the stomach to reduce the volume of the stomach. And we start from the incisor and then gradually move proximally to reduce the width and also the length of the stomach. And last but not least, aspiration therapy. This is essentially a large PEG tube. So the placement is very similar to a PEG placement. And once the patient had the port here, half an hour after they eat, they can connect the port to the device, put in the water, and then aspirate about 30% of the food that they eat. And they can do the aspiration 2 to 3 times per day. So these are the available endoscopic bariatric options out there in the US. So while we know that these procedures are effective at inducing at least 10% weight loss, data have been limited on their effect of these procedures on NAFLD, especially on liver fibrosis. And that's the reason behind this study that we conducted. The goal of the study was to assess the efficacy of the currently FDA-approved endoscopic bariatric and metabolic therapies on NAFLD. It was a systematic review and meta-analysis. We looked at 4 databases from inception to December of 2020. Inclusion criteria included published studies on only currently FDA-approved bariatric and metabolic endoscopic therapies in the US. And the studies have to assess liver-related outcome before and after the procedures. We only included RCTs and observational studies. Exclusion criteria were conference abstracts, case reports, and review articles. Additionally, if the study included less than 5 patients, we excluded those studies. Primary outcome of our study was a change in liver fibrosis following EBMTs, and we looked at both histologic markers and serologic markers. For secondary outcomes, we looked at other liver-related outcomes, including liver enzymes, steatosis, and histologic features of NAFLD, specifically the NAFLD activity score. Additionally, we also looked at other metabolic parameters, including weight, BMI, hemoglobin A1C, and HOMA-IR. We use the CMA software to conduct the meta-analysis. And for the outcomes that the papers reported using different units, we standardized the units using SMD, or standardized mean difference, and it's calculated as I listed here. But just for interpretation purposes, an SMD of 0.2 represents a small effect size. Medium size is 0.5, and large effect size is when an SMD is 0.8 and above. And then we also did a great methodology to assess the quality of the evidence out there in this topic. Here are our results. So by looking at the 4 databases, we got about 5,000 potential studies. We removed the duplicates, so we're down to about 4,500 studies. After that, we reviewed the titles and abstracts, and then removed about 4,000 studies, and then read the full text article on 370 studies. After that, we excluded them based on the exclusion criteria, and in the end, we had 18 studies that met the inclusion criteria. Here's a summary table of the 18 studies that were included in our meta-analysis, and you can see that most of them were published either in the US or in Europe. Out of the 18 studies, 3 were RCTs. Specifically, this study compared a balloon to a sham procedure. And then we had 2 randomized studies comparing aspiration therapy to diet and exercise. The rest of the studies were only observational studies and were included in the meta-analysis. Average age ranged from 30s to 55, and about 70 to 80% were female. Starting BMI prior to bariatric procedures ranged from 30 to 55. And as you can see here, most of the studies only look at patients with obesity. There were 3 studies that also looked at patients with obesity and NASH or NAFLD. Specifically, this study, they included patients based on an MRE result. And if MRE suggested that the patients had NASH, they included. For Lee, they actually did percutaneous guided liver biopsy. And for Espinay-Call, this one, they used serologic markers and also imaging to include patients for NAFLD. Out of 14 studies, 14 of them looked at intragastric balloon. BIB is a type of a balloon. And then 2 looked at endoscopic sleeve. And then 2 studies looked at aspiration therapy. Most studies did a liver outcome follow-up at 6 months after the procedure. And then in the last column in the right, you can see that most studies look at liver enzymes. There were a few studies that looked at MRE, liver steatosis, and then a few studies that looked at histologic features of NAFLD. For primary outcomes, so we assessed liver fibrosis, and out of 18 studies, 4 studies looked at changes in liver fibrosis following EBMTs, and they included a total of 162 patients. Of the 4 studies, 3 assessed the NFS score pre and post, and 1 study looked at APRI score. When we did a meta-analysis, we used SMD because they use different scoring system. And you can see that the fibrosis significantly decreased at 6 months following an endoscopic bariatric procedures. And the SMD was negative 0.07. And if you remember, 0.5 is medium effect and 0.8 is large effect. So it's leaning towards a large effect or large improvement in liver fibrosis following the procedures. Next is secondary outcomes. We looked at liver enzymes. ALT significantly decreased by about 7.8 points, and AST decreased by 3.3 at 6 months following the procedure. Both of them were statistically significant. For liver steatosis, there were 3 studies, including 147 subjects. And you can see that at 6 months following the procedure, the amount of fat significantly decreased by an SMD score of 1. And out of the 3 studies, each of them looked at the amount of fat using different scale. One used the fatty liver index, one study used the HSI index, and the other one used MRI-PDFF. In terms of histologic features, there were 2 studies that assessed NAFLD histologic features pre and post bariatric endoscopic procedures. These included 29 patients, and you can see that the NASH score significantly decreased by 2.5 after the procedure. We also assessed other metabolic outcomes, and we found that on average, the amount of weight loss was 15.8 kilos, BMI decreased by 5 points, and the pooled average total weight loss was 14.5%. From an insulin resistance standpoint, we found that hemoglobin A1C decreased by 0.2% and HOMA-IR, or insulin resistance, dropped by 1.8. All of these were statistically significant. In terms of serious adverse events, we found a serious adverse events of 0.8%, and I listed all of them here. 1 also bleeding in a balloon patient, 1 leak in an endoscopic sleeve patient, and the rest were from the aspiration therapy, including severe abdominal pain, peritonitis, prepyloric ulcer, and skin port malfunction. Subsequently, we also did great evidence profile on studies that looked at liver fibrosis pre and post procedures. As I mentioned earlier, there were 4 studies that looked at liver fibrosis. All of them were observational studies. These were deemed to have serious risk of bias and also indirectness because none of them actually use histologic features. Imprecise because the standard deviation was quite wide. So in the end, using the GRADE methodology, it was deemed that the certainty of evidence was very low at this time and more studies are warranted. In conclusion, endoscopic bariatric and metabolic therapies appear effective at treating NAFLD with significant improvement in liver fibrosis. Given the worsening of NAFLD pandemic, EBMT should be further investigated as a potential treatment option for this patient population. Thank you very much, and I'm happy to open up the conversation to everyone.
Great, thank you very much. Where do you see the research moving? What are you working on now?
Yes. So right now, there are a few things. We're going to have a paper coming out, basically looking at patients who start out with obesity and NAFLD, NASH, maybe more advanced fibrosis. And then we perform these bariatric endoscopic procedures and then assess their liver outcomes as a primary outcome. Because honestly, when we review the papers, it looks like the majority of the studies actually looked at weight loss, and then they just happen to basically check ALT, AST. Right. So we decided to study specifically for liver outcomes. So that is the next step. And then another step would be, what about patients with advanced fibrosis to begin with? Like, can we do this in a higher risk patient population? Because I think for these patient populations, they are very limited in terms of treatment options, because usually when they go to see bariatric surgery, the surgeon will say, nah, you have cirrhosis, maybe we should not do a Roux-en-Y or sleeve on you. Then they go back and say, PCP said, okay, why don't you go do diet and exercise and try to lose 50 pounds? And they can't do it. So I think that will be another very exciting project that we're working on.
Right. I definitely think that's an area that's ripe for that type of research. I guess the other question that I had was, there was an article in Gastroenterology last year that looked at bariatric surgery and cancer risk. With are there any studies ongoing looking at that with these types of therapies?
Not that I know of right now. No one has looked at these procedures and cancer risk at this time. But I think that will be another potential branch out from these therapies.
And then what is the state of art with these therapies in the general, like outside of tertiary care centers? Are these techniques being used? I've seen a couple of local places that are using endoscopic balloons, but any of these other more advanced procedures outside of a tertiary care center?
I think if you look at the prevalence in the entire country, balloons are still the most prevalent procedure being performed. And then that is followed by an endoscopic sleeve with a suturing device. More and more non-tertiary centers are offering this procedure, and there are more and more training courses that offer training for these procedures. So I think it will keep growing, that procedure. But I agree, right now, balloons are still the most commonly performed procedure. But at our institution, the breakdown is 95% of the patients are getting endoscopic sleeve and 5% are getting balloons.
Right. Thank you.
You're
Thank you, Jill.
welcome.
Did anyone else have any other questions, Jill?
Yeah, just a quick question and a comment. So kudos to you for a really well done study, having done meta-analyses. I know they're never easy to do, the rigor of going through all the studies and choosing the right population. So I know you were looking at certain outcomes and looking at studies with a comparator, with a comparison group. Are there any studies with these endoscopic therapies where they may not be a comparator, but they did before and after biopsies long-term, and what are the results of those studies? And then are there any studies, I kind of imagine they are, otherwise you would have put them in, about comparative effectiveness of these different endoscopic therapies, or does it, comparing one versus the other, or do people choose them based on local expertise?
Thank you so much for the comments. So regarding the first question, there have been only 2 studies that looked at liver biopsies pre and post procedure without a comparator. So the patients serve as their own control. One looked at an intragastric balloon, and they did percutaneous liver biopsy pre and then 6 months later. Another procedure came out 2 years ago. That one also looked at a balloon, but they did EUS guided liver biopsy pre and post. And both studies show that liver biopsy or the NAS score improved. However, both studies recruited patients with obesity and NAFLD with basically F0, F1, so very early stage of fibrosis. There have been no study that look at patients with advanced fibrosis so far. Regarding your second question, there have been no studies that directly compare these therapies. There was one study that tried to do some statistics, retrospective, and then compared balloon and ESG. And usually they say everything worked, but none of them have been doing a prospective study comparing devices.
Thank you.
Thank you.
Thank you.
So I had one last question. That was
Hi, Maya.
wonderful. Hi, that was a wonderful presentation. I enjoyed it very much. Who do you think, where do you think these endoscopic interventions fall in the trajectory of where we take care of patients with NAFLD? And who do you think is the right target for these treatments? So you pointed out very nicely that bariatric surgery, there's only a small subset of patients who could qualify for bariatric surgery, right? People, BMI more than 35, plus some comorbidity, or more than 40. But where do you see endoscopic therapies for the larger group of patients with NAFLD? Where should we start thinking about it?
I think, thank you very much for the question. I think the first group, which is the largest group, is patients with a BMI between 30 and 40. So anyone with obesity, basically in our clinic now, we do FibroScan, and I want to say 80%, 85% have some fat on FibroScan. So I think starting at BMI of 30, recommend diet and exercise. And then if they cannot get there, start thinking about bariatric endoscopy early. And then the second group, which is very exciting, are basically any patients greater than 30 BMI and even greater than 40, but have cirrhosis. specifically compensated cirrhosis. And we have been getting more and more referrals for this patient population because bariatric surgery doesn't want to offer a surgery. So then for this patient population, when we get the referral, what we do is that we would perform an EUS guided PPG measurement and also EUS guided liver biopsy. And then if they have compensated cirrhosis, no varices, and their PPG is less than 12, then we offer a bariatric endoscopic procedure. If their PPG is greater than 12, but they're still compensated, we actually start them on a non-selective beta blocker and then repeat the PPG, make sure they come down to less than 12 before we perform the procedure. So that's the second population. And then the third population, which no one has looked into, but I think someone will soon, and we're looking into that, is the lean NASH, kind of like patients with a BMI maybe between 27 and 30, who maybe do the workup and we found that they have NASH, and then maybe they try pharmacotherapy or lifestyle, but just cannot get the 7% weight loss. That would be another population.
Great. Very interesting.
Thank you.
Thank you.
Exciting
Very
field.
good. Absolutely. Yes, we will move on with Maya Balakrishnan, our other co-chair of our Fatty Liver Coalition.
Sure, absolutely. So we're going to be changing gears here. We talked about a potential therapeutic intervention for NASH. We're going to be changing gears and talk. The next paper we discuss addresses the cost effectiveness of screening for NAFLD in people with type 2 diabetes. We have Dr. Mazen Nureddin to present this paper. He, in fact, led and first authored this paper. So Dr. Nureddin has had quite an illustrious track record as a researcher and hepatologist focusing in NASH. His research trajectory really started as a resident at University of Southern California and grew as an NIH fellow and subsequently as a GI fellow at UC San Diego. He's published widely with specific niches in drug development in NASH, with more than 40 studies of novel NASH treatments under his belt. And his second niche, the second area that he's known for, is the area of non-invasive testing and biomarkers of NASH and cirrhosis. And on the clinical front, he is the founding director of the Fatty Liver Program at the Cedars-Sinai Medical Center since 2013. So welcome, and we look forward to hearing about your paper.
Maya, this is a privilege to be here. Maya is a friend. That's why she said all that. It's a privilege to be here. It's an honor. And now I can complain. This is not fair to have an outstanding speaker before me who has endoscopy interest among gastroenterologists. So, and now I'm going to talk about economy and numbers after endoscopy talk. So let me try.
I really look forward to your talk.
Let me try. So that's my paper, I guess, published in Gastro in 2020. And just to keep you interested, that's my first slide. So I have some exciting news as well. Keep looking at the slides. Those are my disclosures. So I'm gonna tell you this as a story and why I did it and what take me to office every day. What made me think about cost effectiveness? Actually, I didn't know anything about cost effectiveness before this. And when I say before this, it's not 2020, it's 2017. This is when I started, or 2018 when I started thinking about this paper. So it took me a while to publish it and learn about cost effective analysis. And I cannot claim that I did the cost of effective analysis. Rather, it was an economist who's also on the paper, but I learned a great deal. So my esteemed previous speaker talked about the significance of non-alcoholic fatty liver disease. And I don't have to tell you this is a pandemic, a problem. Obesity is going up. And as GI and hepatologists, we're all gonna deal with this, and it's just gonna get worse and worse. The type of food is getting worse, the amount of food is getting worse. Now I'm moving to Texas next week. The amount of food significantly is gonna increase. So Maya knows from her patients population where the prevalence of fatty liver, it's not 25% as shown in this slide, it's up to 35 to 40%. But it's thought that the prevalence of non-alcoholic fatty liver disease is around in the 25% range in conservative estimates, actually, and in South America, up to 30%. The Middle East, where I come from, it's also up to 30%, and it's prevalent around the world. But guess what? If you look at diabetes, it's even a much worse problem. And this is a group, I call it elephant on the room, or the beast. You remember how back in the days we hepatologists, like we tell people, oh, look at the ALT, viral loads, so doctors are looking at the screen. And when the patients first come, here what we look for is how the patient look like, what's their comorbidities. It's way more important to me than ALT and AST. And if I see diabetes, this is when I say you should be on your toes. Why so? Because the prevalence of non-alcoholic fatty liver disease in type 2 diabetics, it's up to 50%. 50. That's a lot. And then the advanced fibrosis in type 2 diabetics with NAFLD is up to 10%. It's a significant problems in this group. That means this group is a high risk group, and we should pay special attention to it. Those are data we published just to continue on the significance of the disease. We showed back in 2016 that NAFLD is the leading cause of elevated liver enzymes. I refer to hepatologists. That was known. The reason why they took it to hepatology, because we showed for the first time it's the leading cause of cirrhosis in certain ethnic groups, such as Latino, which is expected, second in whites after alcohol, second in African Americans after Hep C, and leading cause in other ethnic groups. This is also a paper we published in the Red Journal. And if you look at the yellow graph, which I like history of medicine, this is how we got rid of hepatitis C. And kudos to those that they worked on that research. I did back in the days, but that was not the reason why this went down. Other people did the job. But it's a success for all of us when you see the leading cause of transplantation is going down, and it disappeared by now. But at the same time, the mouth factor. What is the mouth factor? I say that because the two phases of liver disease are mouth-induced. One is alcohol and the other one is NAFLD. And what you see now is alcohol is the leading cause of liver transplantation, and NASH the second leading cause. And I think I don't have the slide where I show the leading cause of liver transplantation in women is NASH versus in men, it's alcohol. So it's a significant problem. So those are the guidelines that I immediately after started thinking about the paper. And I don't want to say I was pissed off. Those are my friends. Some are mentors. Some people are leaders in the field. But at that year, there was a debate between Republicans and Democrats. Between EASL and AASLD. And EASL is the European Association for the Study of Liver Disease, and AASLD is the American one. So what the Europeans said, NAFLD is a problem. And I showed you the data for type 2 diabetics. And thus they said, what we're going to do, we're going to screen for non-alcoholic fatty liver disease. But my friends in the guidelines, they said, whoa, in America, whoa. You're talking about how many millions you're going to screen. Do you even have evidence that is cost effective? So when you talk about cost effectiveness, you talk about changing data and actually affecting people's life significantly. And I think UCST, whatever the US mission for changing the guidelines, rely on cost effectiveness data to recommend screening or not. On cancer screening the same way, other screening is the same way. And what they did in the guidance, they were not wrong. They said, there is no cost-effective analysis data. Indeed, there was one paper published in Digestive and Science Disease by a friend of mine who's an excellent researcher at MGH. And what she showed, that if you screen the population, and she went to type 2 diabetics for NAFLD or NASH, it's not cost effective. But what she did at in that paper, she used the liver biopsy as a screening method. Also, cancer patients were not included as much. So to her credit, that's the best she could do, and the paper published a few years before these guidelines. But since her paper, we had non-invasive tests. You don't have to do liver biopsy to find people with significant disease. You have other methods. Indeed, also, since her paper, we stopped focusing on all NASH patients. We still treat them, don't take me wrong. We still monitor them. But what we do in pharmacological trials, we focus on the NASH with fibrosis, F2 and higher. And my colleague in her previous answer, she said, that's the group we're gonna go after. Why so? Because, I'm gonna skip this. It has been shown that NASH with F2 fibrosis and higher, and you see the Kaplan-Meier here splitting in one of the studies. When you get to the F2, this is when the patient is in trouble. And this is when they have liver-related outcomes, such as ascites, hepatic encephalopathy, or expect their chances of that increases, transplantation, and death. And indeed, there was another New England Journal paper that showed the F3 and 4 are more likely to get so, but many data showed that the F2. So I said, okay, the previous cost effectiveness paper relied on biopsy. And it took all NASH comers. So that's a lot of people with an expensive invasive test. And when you do cost-effective analysis, what they take in consideration also quality of life. And just imagine what's quality of life for the liver biopsy. People hate it. People don't want to get stuck with that needle. So we said, okay, we're not going to take all NASH. We're going to look for NASH and F2. Indeed, the F2 is the focus. So we can do that with what you guys all know, transient elastography or FibroScan. And someone might tell me, well, it's not as accurate as the biopsy. You can consider that in your analysis. It's sensitivity, it's specificity, what it missed, what it doesn't miss. So that's what we did. We said, okay, we're going to start screening the type 2 diabetics with F2 and higher using non-invasive testing in type 2 diabetics. So how did we do that? There were data that have been already published, and this is what's called Markov model. And if we have fellows on the call, Markov model look at the life cycle transition of the disease. Who goes to NASH, who goes to F1, F2, F3, how many people go back the other direction, how many people go back to transplantation, and you end up with this spider-looking network of transition possibilities. We had this already in the literature from Zubair Younasi, and he had actually a lot of dollar signs associated with the disease transition, meaning how much it's going to cost me if I go from F3 to F4, how much it's going to cost me if I go from F4 to decompensation. So those are those are one of the things that we look at, the prevalence of each F1, 2, and 3, and the cirrhosis. What's the transition probability? And here I started showing you the numbers, how much it costs to take care of patients, for instance, with NASH. Here we go. One example that we're all familiar with, the last line prior to the second to last is the cost of liver transplantation. And we quoted the literature is $356,000 versus post-transplant care is about $50,000. So you take all that in consideration, analysis that your economist will tell you what to do. And those are more numbers here. What we look at the accuracy of this the tests, how likely they detect things correctly or incorrectly, and you take that into consideration. Given I gave you a lot of numbers, I think I'm just going to jump into the results, because given cost-effective analysis is probably a little bit too much specialized. I forgot to put another endoscopy picture, but I have FibroScan pictures here. So the way we did it, you also can do control. Like what we did is we said, okay, let's start with ultrasound with or without liver enzymes. So you see here 3 scenarios on the top that they go up to 6 scenarios on the bottom. How so? You start with ultrasound with or without liver enzymes, and then you either do liver biopsy or FibroScan. So you see on the bottom now you have 6 scenarios. You start with ultrasound, for instance, on the right, and then you do liver biopsy to discover NASH and F2 again, or you start with ultrasound and do FibroScan to discover the F2s. But also when you discover them, it's like when you screen, you need to do something. Otherwise, it's not going to be effective or cost effective. When it's going to be cost effective, you need to stop the disease. You need to reverse it. And here we offered the intensive lifestyle intervention that my colleague talked about. We offered the weight loss and exercise because we did not have data on endoscopy, for instance, when we did this. And the cost of it needs to be considered. But all you need here to know if the screening is cost effective or not. And we used intensive lifestyle intervention based on a paper published in Gastroenterology by Villar Gomez. We also looked at pioglitazone, and when you use medication, their side effects go into consideration. We even price the intensive lifestyle intervention. How many visits the doctors, how much they charge. And as you would expect, the control, which was liver biopsy, was not cost effective. Versus if you start with any of these, ultrasound or AST or ALT, then you follow it by FibroScan with sensitivity and specificity, you get to NASH and F2, and you go to lifestyle intervention, you are cost effective. So here we recommended to screen the population type 2 diabetes starting at age 55 and higher for non-alcoholic fatty liver disease. Now, we projected if we start based on statistical or methodological analysis, actually, if you go all the way to age 40 in type 2 diabetics, you're still cost effective. So that led to my treating my anger issues with the initial guidance. So I was very pleased a few years later that the AGA this effort was led by Dr. Kanwal, who works with Maya, that they put a call for action paper that acknowledged the risk factors of non-alcoholic fatty liver disease. And indeed, for the first time, someone says, if you have type 2 diabetes, you do have to screen. That here they start with FIB4, followed by the FibroScan. And I was very pleased to see that they quoted our paper that now data showed cost-effective analysis, and thus we recommend to screen for non-alcoholic fatty liver disease and type 2 diabetics. Though the other people are, of course, steatosis or elevated liver enzymes, you need to work the patient up for sure. And they also recommended 2 or more metabolic risk factors based on data came from Baylor. This actually needs cost-effective analysis as well. But now it's in the guidance, and my anger issue is gone with the guidance. We're waiting for a new guidance. I do expect that screening will be there, and it's already in the European. The ADA has also moved towards screening in type 2 diabetics. So what you need to know today is that you need to screen for your patients that they're type 2 diabetics or not. You need to tell your for type 2 diabetes, you need to tell your primary care that this is important. And trust me, you can save lives. A lot of our patients came to us all the way with cirrhosis and metastatic liver cancer because they were told one day they have fatty liver and no one staged them or screened them for fibrosis, or even they never looked at their non-alcoholic fatty liver disease. thank you for having me, and I'll take questions.
Wonderful. Thanks for breaking down that paper that's fairly foreign to us doctors. We don't think that much about cost effectiveness analysis, so that was great. This paper is open for questions while we're waiting for others to think about their questions. I had a couple for you, Mazen. So, in your cost effectiveness analysis, you took into account that, there's potential treatments that can make fibrosis better and therefore mitigate cost of worsening disease over time, right? That's part of the analysis. So could you talk a little more about sort of some of the assumptions that went into the effect of specifically pioglitazone on fibrosis? Because the studies haven't shown that pioglitazone helps fibrosis, but you guys did something in your paper to take into an assumption that pioglitazone would improve fibrosis over time if started. So could you tell us a little more about that?
I love that question. It's extremely smart, actually. I mean it. So if you see, I have in my slide intensive lifestyle intervention. I did not have the pioglitazone. I just mentioned it verbally. The intensive lifestyle intervention, we took in consideration the cost. We took in consideration that only 10% achieve it and keep it. We took the percent, they have to get to 10%, so fibrosis removed, so a change outcome. So that all went into the soup of that analysis that is very complex. Now we send the paper to Gastro, and we really got good reviewers. And I initially went back and forth on PO. Should I include it? Should I not? Should I include it? For the reasons you mentioned, because we really rely on this paper on changing fibrosis. And I don't want to go too technicals, but we got one of the reviewers asks, and they were really good. They improved our paper, but I think one of the reviewers was pro pioglitazone. And there is a meta-analysis showing that pioglitazone possibly move fibrosis in type 2 diabetics. There was a study and a sub-analysis they showed it also might improve it in type 2 diabetics. Nevertheless, I'm actually in the same opinion like you that I'm still doubting pioglitazone ability to change fibrosis. And to make the story short, we included as secondary analysis. We put the pros and cons of these studies. Of course, you have to take their side effects in consideration, all this. And we said it's we need more data on pioglitazone ability in improving fibrosis. Yet that does not affect the big decision of screening type 2 diabetics, because we have a clear message from the intensive lifestyle intervention that we took all its components in consideration.
Great. So I just want to make sure I do understand the bottom line, though. So the bottom line is that it is cost effective to screen for NAFLD in diabetics if we are to offer them intensive lifestyle intervention. It's the whole gamut, right? That makes it cost effective.
Correct.
So how has this paper affected sort of your practice at Cedars-Sinai? So what's the message you've delivered to your primary care doctors, and how have they changed their practices?
Yeah,
or even the endocrinologists?
We previously said, I used to give them the spiel about that. If it's me, it's my family member. If they're type 2 diabetics, I'll screen them. This is before the study, before the AGA, before when the ASLD guidelines said it's too early to screen. And I used to say, if it's my family member, I will screen. But now with confidence, and some started screening, some not. Now with confidence, backed up by the AGA, again, they use our paper to show its effective analysis. With the new ADA kind of leaning more towards screening, now it is much easier to talk to to them, and I'm sure you went through this. Some endocrinologists are very receptive, and many, they're like, so what? We see a lot of fatty liver, nothing happens to them. And then you don't have treatments, yada, yada. But now it's with, as you know, a lot of people change their practice when the guidance change. So that helps significantly in increasing the screening rate.
So I have a question, then. So excellent paper, and
Thank you.
Really much needed in our field. So I share your frustrations about the SLD guidance.
And by the way, the endoscopy is not part of it.
No. So
Maybe for your next paper.
Sure, we'll work together.
Yeah.
Yes, sir.
So in terms of the treatments you mentioned, so obviously the cost of it comes from the treatment, and that's an ever evolving field as well. What were some of the case assumptions you used for the durability of the response? So we know, that weight yo-yos, and we don't know how long the benefit of treating F2 and F3 lasts. Is it forever? And so how long were the treatments? What was the cost? And what was the time duration of follow-up in this case study? And what is your belief in how cost effective is it really at age 40 versus 55 or even younger to screen?
That's an excellent question. So the paper should be data driven, and I did not include that in the details here, but the intensive lifestyle intervention that we used was data driven from a paper by Villar Gomez and colleagues published in Gastro many years ago, very highly cited paper. It was a study that done in Cuba over 1 year period. In the 1 period, they show you how many people respond, and this is where the 10% only responded in NASH patients. How many respond, how many they don't respond, how much fibrosis improvement you see in F2 patients, how much fibrosis improvement you see in F3 patients or cirrhotics. There were no cirrhotics in that study. So we use that 1 year life cycle in change, which in the changes, which is actually very conservative. Why so? Because we are taking only the improvement that happens in 1 year of lifestyle intervention from F3 to F2, for example, or F2 to F1. We don't go beyond that because we don't have data beyond that. So just imagine if we had data on how much more in year 2 and how much more in year 3, it would have probably been more cost effective. But we don't want to make assumptions, and we just use conservative number. And that was actually good for us in publishing, because we said, well, we're just using 1 year and tough numbers, and we're still cost effective.
Sorry, so I was just making the point. I completely agree. If you look at the bariatric literature, some of especially with surgery, and I'm sure with endoscopy coming up too, some of those benefits accrue over time. So it's a cumulative benefit that keeps increasing, as far as fibrosis or regression is concerned. Over 5 years, it's not 1 or 2, which is the limit of some of these studies as well. And I think you'd be happy to see that more societies are falling in line. So the VA just put out a guidance document, which is very similar to AGA for the entire VA organization, which is endorsing screening for NAFLD and type 2 diabetics.
I don't know. Nice. Good to hear.
Dr. Naradan, congratulations on your wonderful paper. I love it. Love the numbers. I have one quick question. In your Markov model, did you take into an account a patient's BMI when you start the Markov cycle? Especially now with the Anticipate study, we know that with patients with obesity, if BMI greater than 30 or 40, the accuracy of FibroScan is decreasing. I assume it's going to be cost effective still, especially in this patient population, but I wonder how you see that maybe like in the future being part of the guideline or guidance.
So the great question. So the Markov model, again, that was published already, so we used it, included all NASH patients And the only sub-analysis we had with Markov models with type 2 diabetes and without type 2 diabetes. It is very hard from these Markov models to tease out the BMI. So it includes NASH and no NASH. I'm sorry, it includes all types of obesity. Now, in terms of the FibroScan, it's another good point, but we actually take in the sensitivity, specificity, MPV and PPV of the FibroScan performance on the entire NASH population, which match our population, and we reduce, the rate of detection or not based on these numbers. We tried to do sub-analyses for, I wanted to recommend it for obese patients or patients with metabolic syndrome. And we could not tease out a good Markov model or build a good Markov model in the literature based on those. Because type 2 diabetes in general is more well detected in our NASH papers compared to the obesity and metabolic syndrome percentage, especially metabolic syndrome. Was very hard to tease.
Dr. Nureddin?
Just
Thank you.
one. Oh, sorry, go ahead.
There's a question from the chat here. There's Lina has joined us. She's an internal medicine resident, and
my
she has a
God.
question that was there any role in considering the A1C in regards to the screening?
Yeah, good question. I would say all diabetics. The data on A1C, for the longest time, we assumed that the worse A1C, the worse NAFLD and NASH. And we really didn't, although it's plausible, we didn't have good data until recently, a year or so ago, that, it's if your diabetes is less controlled and your A1C is higher, you want to, your NASH is worse. So no, we did, I will say it doesn't matter what's your A1C. Once you're diabetic, you should screen whether your diabetes is well controlled or not. And we took all that in consideration in the analysis. We even looked at cardiac outcomes in this paper, just not liver outcomes. But yeah, I would not recommend screening in the pre-diabetics because that's much larger population and way more cost probably. So I don't have cost effective analysis on these data. But if you're diabetic, no, regardless of your A1C, I would say go for it. And Lena, you just got in GI because of your question. You're interested.
So
Attending.
Mazen, I have one more question for you, a little bit of a challenge. So we've all been very nice to you. You're a friend, but I want to play devil's advocate.
I have to go.
I know you have. So, so your cost effectiveness analysis makes the assumption that if someone's identified to have severe fibrosis, they'll be treated with an intensive lifestyle intervention. But the reality is that in our current world of practice, most patients don't have access to intensive lifestyle interventions. We don't have the funding for it. People don't have access to it, so on and so forth. So given real world practice settings, is screening for F2 really cost effective?
If you don't do intensive lifestyle intervention, the answer is I don't know, because no studies have been done. And if you want me to predict, it's probably not, because you and I and everyone on this screen know the pressure of the time and our views and how much we spend time with our patients. Yet we have to get 9.9 on the survey from them. We also all know on this call that unfortunately, dietitian consultation is not covered for non-alcoholic fatty liver disease by most insurer, which is sad. It's covered for diabetes and not for non-alcoholic fatty liver disease. So I will say probably not, but that doesn't mean we shouldn't do it. That doesn't mean we just leave them without treatment. It's probably the answer. If you've in a type 2 diabetes, you should probably find if they have it or not. And if they do, we really can do big changes by, even if it's long-term changes, by implementing intensive lifestyle intervention on these people.
Right.
So,
Of course. Well, thank you. And of course, the landscape is expanding with GLP-1 agonists and so on and so forth, endoscopic bariatric procedures.
yeah, and
so
there
on.
are people are moving. There are there are apps that they are coming out. There's
Yeah.
I don't have, it's not my disclosure. I don't have them. Noom and others, that's the first thing come to mind. So hopefully with digital medicine, now we're open-minded for it, other methods, that things will change.
Right. Wonderful. Well, thank you so much, Mazen. I'm going to hand it over back to to Jill.
Thanks.
Mhm.
Thank you so much. Well, everybody who's on this call right now, if you're interested, you can join our Fatty Liver Coalition with the Community Liver Alliance. We are developing programs like these journal clubs. Also, we have a review annually that takes place in November. So we'd love to see you all there. Invite your colleagues, and if you're interested in participating, certainly send me an email. We'd love to have you. Lastly, we have Henry Chang, who is the executive director of the Fatty Liver Alliance. Fatty Liver Foundation.
That's right.
And they are starting a new initiative that he's going to tell us about as well before we close out for the evening.
Great, thank you, Joe. And it's just such an honor and privilege to join so many luminaries in this space. And I took copious notes, Mazen. It's always amazing to see what you can achieve, when you get angry. So it's congratulations again on that paper. So I'm with the Fatty Liver Foundation, as Joe mentioned. We've launched an initiative which we believe it's the first of its kind, called the State of NAFLD NASH Care in America initiative. And the goal is to survey 2,000 Americans with NAFLD NASH, and just to better understand their lived experience, and the hope of contributing to the improvement of the overall diagnosis, treatment, and care for people with NAFLD NASH. I'm gonna just, in the interest of time, drop the survey instrument in the box, if that's okay. Our goal is to hopefully be able to present our preliminary findings at the liver meeting, AASLD liver meeting in November. And this really is the first effort that we hope to turn into an annual exercise of gathering the lived experience of people with NAFLD NASH, and ideally be able to also help contribute to the discussion that you've all been having here in advancing clinical research, but also trying to impact policy setting. The issue that Mazen had raised, which was actually new to me, that dietitians are not being covered by insurers for NAFLD NASH. So hopefully that's one of the key areas that we can also work on as an advocacy issue for our patient population.